Hello, my name's Dan Riedel. I'm a cardiology fellow at Summa Health System in Akron, Ohio. Today for you, I'm going to present a case entitled Atypical Presentation of Left Circumflex Artery Occlusion Following Mitral Valve Replacement. Thanks to Dr. Ray and Dr. Iafor for assisting me with this case. The day of the recording is 9/11/2022. Introduction. Left circumflex artery injury is a rare complication of mitral valve surgery. It occurs in 0.5% to 1.8% and is associated with high mortality and morbidity. We discuss a complicated case with diagnostic and therapeutic challenges. So to the case. A 72-year-old female with a remote history of rheumatic fever, long-standing mitral regurgitation, atrial fibrillation, and left bundle branch block was referred for left and right heart catheterization for worsening dyspnea. Catheterization showed left dominant coronaries without significant disease, substantially elevated left and right heart filling pressures, and low cardiac index of 1.4 liters per minute per meter squared. She was admitted to the cardiac care unit and underwent swan-guided optimization of her cardiogenic shock with nitroprusside and furosemide. Transesophageal echo demonstrated severe MR, severe tricuspid regurgitation, severe mitral annular calcification, moderate mitral stenosis, and an ejection fraction of 40%. After optimization, she underwent bioprosthetic mitral valve replacement with a 31 mm St. Jude Epic valve, tricuspid valve repair with a 34 mm Medtronic contour 3D annuloplasty ring, and left atrial appendage ligation. During surgery, she was hypotensive and hypoxic, requiring epinephrine and veno-arterial extracorporeal oxygenation. Intraoperative TEE demonstrated stable LV function and minimal residual regurgitation. She initially improved and was weaned down on supportive care. However, that afternoon her blood pressure rapidly declined. Electrocardiogram was unchanged. Bedside echocardiogram demonstrated new severe left ventricular dysfunction with an ejection fraction of 10% with a dyskinetic lateral wall. After interdisciplinary discussion between cardiothoracic surgery and interventional cardiology, left heart catheterization was emergently performed with placement of Impella for hemodynamic support. Mid-left circumflex had a new 99% stenosis, likely due to mitral valve suture impingement. Percutaneous intervention with drug-eluting stent restored adequate flow. Though LV function improved to 35%, her postoperative course was tumultuous. After a month-long hospitalization, she was discharged to a long-term acute care hospital. Discussion. Left circumflex artery proximity to the mitral annulus makes it susceptible to injury during mitral valve surgery, and left dominant coronary circulation increases this risk, as seen above. Our case demonstrates an atypical presentation of left circumflex injury following mitral valve surgery and highlights the importance of having a high level of suspicion. Intraoperative TEE did not demonstrate significant LV dysfunction, though this may have been masked by inotropes. Support was initially weaned, and evidence of ischemia on electrocardiogram was likely concealed due to left bundle branch block. Point-of-care echocardiogram was valuable for recognizing significant global and regional dysfunction, resulting in prompt left heart catheterization and intervention. Normally, PCI is not recommended when the left circumflex artery has significant stenosis following mitral valve surgery. Rather, bypass is preferred as it is difficult to angioplasty the vessel. However, here it proved life-saving and likely successful because the vessel was not completely occluded. Conclusion. Left circumflex injury is a rare but serious complication following mitral valve surgery. Although LV dysfunction is common, concern for left circumflex compromise is needed when supportive care is escalated and early angiogram is imperative to assess coronary anatomy. This case demonstrates the importance of expedient identification of left circumflex injury, multidisciplinary communication, and that left circumflex PCI is a viable option of this surgical complication. Down below we have figure 1. Figure 1A is a left coronary angiogram which demonstrates a 99% occlusion of the mid-vessel due to suture impingement after mitral valve replacement. And then figure 1B demonstrates post-balloon angioplasty and placement of drug-eluting stent. And as you can see, the flow on the still image is significantly improved. Thank you.